can't see you, but
we're not on.
oh yeah, that's all right.
Is it screwed it up because I'm in? I'll sign in as. Oh God, I'll sign in as me. I'll come back in.
No.
Okay, it's just that with miniaturized video views, I think Sheriff looks like a very young and better looking version of you.
Which is true. He's seen me in real life. No, I'm only joking. Nice to see you, Mick. Okay, so let's get started. Welcome everybody to the BOMSS webinar this evening. It's the 13th of April, 2022, and we are delighted that the amazing team from Portsmouth and Co will be joining, and Streamline also will be joining and delivering the Journal Club tonight. So I'm Sharif Howard, consultant bariatric surgeon in Derby, and co-chairing with me is Roxana Zuccheri, also the trainee rep on BOMSS. I'm educational lead for BOMSS. So before we start, would like to thank Gore for sponsoring the Journal Club tonight, and want to give you a heads up about the next educational event that we'll be holding. So the last Wednesday of the month, Wednesday 27th of April, Shaw Summers, who is the host for this evening, will again be hosting and delivering a really, really important session on the gastric band and how to make it work and how to avoid, more importantly, avoid long-term complications and try to get a good result from it. So we look forward to that, Shaw. And without further ado, can I introduce Shaw Summers, very, 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 very senior and absolutely fantastic, supportive consultant bariatric surgeon from down south, works with Streamline, former BOMSS president, and loads and loads and loads of other things. So Shaw, welcome and thanks very much for supporting, and we look forward to listening into your Journal Club.
Thank you very much, Sheriff and Roxana, for asking us, the team at both Portsmouth and Streamline, to host this. I thought that we ought to do two really straightforward subjects that I think have practical application for all of us. And I think it's always worth scanning the journals for things that have real day-to-day worth in our practice. So I've got two of my great colleagues, young upcoming stars in the field of bariatrics, who are going to talk a little bit about papers that have caught their attention. Firstly, we've got George Hamlin-Williams, our clinical services lead at Streamline, who's going to talk about some allied relevant topics, but I think it's a broad relevance to all of us. And then Mike Glacier, our senior bariatric fellow at Portsmouth, who's going to talk about a subject that's close to my heart, certainly, but he's become interested in also. So without further ado, George, would you take the centre stage and tell us your paper in the next 10 minutes or so? Thanks.
Thanks very much, Sean. It's a pleasure to be presenting this evening. So I'm just going to share my screen. Okay, so hopefully you can all see that. So as Shaw said, my name is George. I'm the clinical services manager for Streamline. I'm a dietitian by trade. I've been working in bariatrics since 2008, only ever in the private sector, which is a little controversial, but there you are. The paper I've chosen today is this, which is the reversal of long-term weight gain after Roux-en-Y gastric bypass using liraglutide or surgical revision, a prospective study by Horber and Steffen, which was published last year in Obesity Surgery, a well-known journal that you will all be aware of that has an impact factor of 3.3. So in terms of why I chose this particular paper, according to a systematic review, up to 1 in 4 bariatric surgery patients experience weight regain, and I'm sure this does not come as a surprise to any of us. Though the definition of regain is inconsistent, so it varies a lot. So it could be the number of kgs regained, the percentage of the total weight loss that's been regained, the percentage of the excess weight loss that's been regained. So this is a problem in the literature because it can't really be defined. Now there's good success and similar risk profile in terms of the band to bypass and sleeve to Roux-en-Y gastric bypass in terms of weight loss outcomes. But Roux-en-Y gastric bypass revisions have been associated with quite high percentage complications and nutritional issues. Now, the thing about weight regain is that we can consider some of it normal, but what we can be fairly sure of is that regain is associated with reduced quality of life and some comorbidities resurging. Now, the problem also with revision surgery is that not all patients are suitable for, can afford or want revision surgery. And certainly in my experience in the private sector, this is a very real problem with the weight regainers. And so, you know, we potentially need something else to help these patients. Now, liraglutide, as you'll know, was introduced in the UK for weight management in 2017 as an adjunct to lifestyle intervention for patients with a BMI over 30 or with a BMI over 27 with one or more comorbidities. You probably are aware, but the dosage of liraglutide increases from 0.6 to 3 milligrams over the space of a month, with 3 milligrams being the maximum dose, and the trials suggest about an 8% total body weight loss after 56 weeks, but crucially exercise and diet counselling alongside. Now, I qualified as a supplementary prescriber a couple of years ago, specifically to prescribe liraglutide, and actually in my research I came across quite a number of papers on the use of liraglutide in weight regain after surgery, and that's what kind of made me choose this paper. So in terms of surgical revision, there's a number of papers out there. This scoping review I found quite useful in terms of looking at the risk, and there's several thousand papers, individual papers, when we're talking about the looking at individual series of data. And this is another systematic review that was done. But what we can say is that the weight loss is pretty good. So around about 50% excess weight loss after lengthening a gastric bypass, about 30% potentially after endoluminal treatment, and this is a systematic review that looks at that. In terms of the use of liraglutide after bariatric surgery for weight regain, there have been quite a number of papers ranging over the last 10 years, but they're very small sample sizes, varying from as low as 15 to 145. Though none of them specifically focus on the bypass. They look at different operations, but the average total body weight loss varied from about 5 to 10% in these. So around about what you'd get in the non-surgical population. But I was unable to find any papers directly comparing revision surgery to liraglutide, which is what made me choose this paper. This was the aim of the paper, to compare the two. And the study design was that it was a prospective cohort study in a single centre private practice in Switzerland, and they looked at absolute weight loss and percentage of the regained weight that was lost. Inclusion criteria was that they had to have had a gastric bypass at least 6 years ago. They had to be over 18, and they had to have regular follow-up at least every 6 months after their bypass, and they couldn't have alcohol or drug abuse. In terms of treatment allocation, well, you'll have read the paper, so you'll have seen that they split them into patients who'd regained less than 10% of their weight and patients who'd regained more than 10%. They used the less than 10% regain group as controls, and the rest they split into liraglutide, endosurgery, and placing a minimizer ring and resizing the pouch. Patients chose their treatment, they weren't randomized. In terms of follow-up, they detailed that it was surgeon-led, and they had follow-ups at 4 weeks, 8 to 12 weeks, and then roughly every 3 months until 2 years. And the control group were offered lifestyle and dietary counselling. They didn't give any detail of this, every 3 months. And that was for the control and the liraglutide group. The surgical groups had additional counselling with the dietitian regarding the initial post-op diet. They collected baseline characteristics, including the usual in terms of gender, age, weight, the amount of weight they regained, their BMI at the nadir, and then, of course, their post-treatment weight BMI change, as well as any side effects and change in comorbidities, and they've defined them as follows. So in terms of analysis, they looked at the differences between groups using various statistical analyses, and they used SAS or SPSS for this. In terms of results, we can see here that they looked at the different groups of the baseline characteristics, and they identified a difference in the phobia ring group in terms of age and weight, so that they differed significantly in age and weight compared to the other groups. In terms of the post-treatment weight loss, you can see that the controls kept their weight pretty much stable. The liraglutide group lost about 5 kilograms per meter squared, as did the phobia group, and the endosurgery group lost about 1 kilogram per meter squared. In terms of side effects, there were no side effects in the control group. Nausea was the only reported side effect in the liraglutide group, and that resulted in about half the patients not reaching the maximum 3 milligram dose. In the endosurgery group, 1 patient required 2 gastroscopies due to unexplained abdominal pain and reflux. And in the phobia group, 6 patients experienced complications, which was significantly different to the other groups, including severe upper abdominal pain, internal hernia, penetration of the minimizer ring, and 3 patients required gastroscopies, with 1 poor patient requiring 32 endoscopic dilatations. In terms of the change in comorbidities, well, in the liraglutide and minimizer groups, as you might expect, they showed the most improvement in terms of comorbidities, with that being statistically significant in some of those cases. There was, in the control group, an actual increase by 1 patient in the number of patients with diabetes, as you can see there. So in terms of the study, now obviously it's a small sample size. There was only 95 patients in this study, and there's definitely a selection bias going on with it being only a Caucasian population in 1 country in a single centre, and the patients being privately funded. They only looked at weight loss after weight regain, after Roux-en-Y gastric bypass. They didn't look at all operations, so that's potentially a limitation. They weren't randomized, so they chose which group, which could again introduce problems. The groups weren't matched for age and weight, and you saw that with the phobia group, that was actually statistically different. And the groups weren't the same size, although it doesn't look like they analysed that statistically, which I thought was interesting. And most interesting for me was that there was very little detail regarding what dietary and lifestyle counselling meant. Did it include dietetic support with a dietitian, and did it include written literature? What did it include? And if they did see a dietitian, well, how often, when did they see them, how long did the dietitian spend time with them? And the other thing that I haven't put here on the slide, but is any psychological input with these patients. And they certainly didn't consider any nutritional complications. They haven't kind of looked at any nutritional complications with any of individual treatment. In terms of benefits of the study, well, they were followed up very regularly. They had 100% follow-up. They did use a control group. And as far as I'm aware, it's the first study that directly compared revision surgery and liraglutide. And they measured the weight in clinic rather than being self-reported. And they've got pretty long-term follow-up compared to other studies on liraglutide use after bariatric surgery. And the results do suggest that liraglutide has the lower risk of complications and can give a similar weight loss to revision surgery, potentially filling a treatment gap. And that was the conclusion that the author came to as well. But they've said that definitely further research is needed. In terms of changes in practice, and these are the kind of questions I'd like to put to the floor, is should we be offering liraglutide as a first-time treatment for weight regain after post-bariatric surgery? And if a patient is regaining weight, how long should we wait before suggesting it? Should we nip it in the bud? And should we include regular dietetic input as part of the treatments? I know what my answer is, obviously, but if so, how often should we include it? Thank you very much for listening. Hope I haven't rabbited on for too long.
George, it was a lovely, lovely, clear presentation on quite a topical and important topic. So the changes in practice questions were exactly what I was going to ask you. So why don't you have a go answering your own changes in practice? What do you do in Streamline in terms of liraglutide use and prescription and so on?
Sure. So we see patients for weight management with liraglutide. They see a dietitian as a first line option. So we talk through their medical history, we look at their medications, and we have created a protocol whereby we have criteria that the patient has to meet to be able to qualify for treatment with liraglutide. And then we go through their diet and we assess if we think it's going to be beneficial to them, and then if it is, then we'll then refer them on to have it prescribed by one of our surgeons.
What's your typical patient that you would refer on for it?
Well, if we're talking surgical patients, so we do see patients come in who've not had bariatric surgery and they just don't qualify for surgery because their BMI might be lower. But if we're talking weight regainers, I would say it's typically 5 to 10 years after a bypass. Their BMI probably went right down into the 20s and is now back up into the high 30s, early 40s. Usually, actually, though, when you talk to them, lots of things have happened in their life that have kind of led to this. It's not just been that they've got hungry and that's it. There's other things going on. So obviously there's always an element of it being a bit of a punt, which I personally is why I think liraglutide should be used first. Because actually, if this problem does go deeper and it is more psychological in nature, then actually revision surgery certainly isn't, in my opinion, a good idea, and you should be seeing if something less invasive might work.
This is exactly the approach we're taking, because certainly in my experience of doing a lot of revision surgery, about half of my practice is revision now, both in the NASH and privately. And, it is thankless. There is no good data to guide us with revision of bypass, and specifically with a bypass is because it was the commonest procedure until about 5 or 10 years ago. There are a lot of patients who are coming back with fatigue in their bypasses. I don't use the word failure. It's just like any benign physiological operation, it fatigues with time. The tissues slacken. So we've been very surprised with the results, certainly in those patients who are borderline fit for surgery. So they had their bypass in their 40s and 50s. They return with weight regain in their 60s, late 60s, and you're thinking, am I really going to dystalize and this bypass and shorten, reduce the pouch in someone who's in their late 60s with the possibilities of osteoporosis, etc.? No, this is the way to go for the time being. And I think the other point that I feel very strongly about is cost. Revision surgery is a big ticket item, and there's no guarantee it's really going to work, both in the NASH or privately. It's a lot of money to spend on something that may or may not work. And if we can use liraglutide early, I think you can avoid people having significant weight regain by a simple drug that you can turn on and off that is not that expensive compared to surgery.
Agree completely. And in terms of timing for intervention, when do you think we should wait until that typical patient 5, 6, 10 years down the line, or intervene a little bit earlier? Should we hold it in reserve?
Well, I think this is where you have to be careful expectation setting with the patients. Patients need to know there is a nadir and a weight rebound always at about 2 to 3 years, and that's natural and normal. If they're fearful of regaining that 10% up to of the weight lost, they're going to be banging your door down for something that is really not achievable, and you can't be putting most of your patients on liraglutide. So we really have to try and save it for the ones that are really struggling. And exactly as George says, it's a great initiator for looking at the whole patient psychologically, dietetically, giving them some treatment and seeing how they respond and how they react to actually working with it, because I think that's a very good yardstick for judging how they're going to do.
And roughly cost-wise, in terms of per month for a patient, say privately, who are wanting to take it?
Privately, on average, just the plain drug costs are about 250 quid. But I counsel all patients, please don't just buy it off the internet and jab yourself. You need the dietetics, you need to be in a program of care, you need the psychological support. It's a bit like just going out and buying a chainsaw and going, yeah, I'll knock a few trees down. It's just like, not so good.
Package. Okay, just in the interest of time, Roxana, do you have any questions you'd like to put to George?
No, I was just going to say it's interesting just in terms of what you're saying about fatigue, because we always think room-wide gastric bypass works by increasing your GLP-1. So what makes this, what this paper shows, that at least people can, even despite fatigue from the surgery, have some response with.
It's one of the ways it works, I think, Roxana.
Yeah.
You know, it's the way we can measure quantitatively. I would beg to not make that the only important thing about a bypass. There is the shock and awe phase of restriction, which does happen. And if you don't put that in the mix and you make a nice big anastomosis in a big pouch, it doesn't work as well in the long term. Anyway, 20 minutes have gone past. We've got another 20 for Mike Glacier. So thank you, George. That was great.
No problem.
We can return to it if there's any questions that pop up on the chat. Mike, the stage is yours. Tell us about your paper.
Fantastic. Let me just share my screen and hopefully you can all see that. Good evening, everyone. Thank you very much for giving me the opportunity to talk and present our second paper from Portsmouth. Slight change of tact. It's a bit of a technical paper, but I hope you enjoy hearing about it as much as I've enjoyed reading about it. So just a bit of a background as to why I and we have selected this paper. Essentially, this came up mainly as an observation within our own department, primarily where we noticed in between surgeons, there's different methods of how we're measuring bowel lengths. And this obviously led to the greater discussion that's been going back many years of what is the best, I say loosely, way of measuring bowel length that's the most accurate, the most consistent, and is it important? So from our point of view as bariatric surgeons, obviously it's fundamental to all aspects of diversionary surgery. We want to make sure that we're accurately measuring our limb lengths. Primarily we're talking room-wide gastric bypass, but obviously we're talking BPD and other forms of operations. We want to make sure that patients are getting the operation they need, the limb lengths are correct, so they're getting the metabolic diversion they need, but equally that we're not overestimating their limb lengths and we're causing nutritional deficiency. So the clinical importance is clearly there. And we also need to consider beyond our remit. So we think bariatric surgery is obviously the best, but of course we need to think about intestinal failure surgery, IBD resections, oncological resection margins, and urological applications as well, to where this is also important. So I've had a look through, some of our main trials, and you can see just from this selection on the right-hand side that even within our UK and European trials, there is no consensus on how we're measuring our limb length and measuring our small bowel. And so there is no consistency. And even if there's not a clinical application, surely we should be getting accurate limb length measurements for when we're comparing between trials. So this led to the conversation between ourselves, well, this will be a nice trial to do. We should sit down and compare the different methods of measuring small bowel. But to our dismay, someone had already done it. So we fell across this paper by a German team who have very nicely compared some common conventional methods of bowel length measurement and during laparoscopic surgery, and compared it to their own novel computer-assisted 3D measurement system, which I'll go through with you now. So to summarize, it's a German surgical group, which was nice to see that they consist of a urologist and some general surgeons. And it was published in the middle of last year in Obesity Surgery, which is of course our bread and butter with a moderate impact factor. It's worth noting it's a non-human, it's experimental paper, which I found very interesting to read. And the authors very nicely stated that ethics was not required as no patients were involved. But it was nice to see that they still went through their institutional review board, and all the subjects who were involved, which I'll go on to, were providing informed consent. So it's nice to see, sound methodology. Primary objective was to essentially compare existing methods of laparoscopic bowel length measurement, and through their literature review, they deemed the most common ones to be visual judgment, which they put as their control because it didn't incorporate using a formal measurement instrument or technique, and then compared this to instrument markings, pre-measured tapes, and then against a self-developed computer-assisted 3D bowel measurement system. And I think it's important to mention that it's self-developed by the authors of this paper, so that we can, take that into account when we're interpreting their conclusions and applications. So just to briefly mention their methodology, particularly for obviously the non-surgeons in the chat. So they compared these 4 methods. So A on the top left is essentially just a simple visual estimation of how long the bowel is. It's important to note that they used just a normal laparoscopic box trainer. They used a 3D camera, 3D glasses, and what they called a phantom model to replicate small bowel, which is essentially just a cotton sleeve, but stuffed in such a way that it handles like small bowel, but obviously without any mesentery. So with the visual estimation, just passing hand over hand, totting it up in the surgeon's mind in order to guesstimate when they've measured a certain length. B is the formal instrument measuring. So in this paper, they used 5 centimeter increments. And so they judged this by using the end of their Johann until the K of the Karl stores on their Johann, and they would walk along it in 5 centimeter increments. C is using a pre-measured tape. So in this study, they used a 35 centimeter nylon tape, which they would run along the length of the bowel in order to estimate their length. And then finally, D is their 3D modeling system, which they fully describe the methodology of in a separate paper, which is referenced at the bottom, which is also an interesting read if anyone fancies it. But in short, essentially, they have a length of bowel, which they put between their 2 Johanns. They press a pedal, and then it gives them a bowel length measurement, which then tots it up on the screen for them. So it takes out the human error of having to count it up. So they had 63 participants in total that tried all these different measurements in turn. It's worth noting there are 21 surgical residents, 30 medical students, and 12 medical test persons, notably no bariatric surgeons, which I'll come on to. Their intervention, as I say, was the instrument measurement, the pre-measured tape, and the bowel measurement system. And they chose, they asked the participants to measure 70 centimeters along a pre-measured 100 centimeter phantom. And they chose 70 centimeters as that's the standard biliary pancreatic limb in their institution. And then they used the visual judgment as their control. In terms of determining accuracy, they worked out the absolute error of each participant's measurement, but also worked out the relative error, which is quite nice, and I'll explain that in a moment. They worked out their measurement time in seconds and also the number of bowel grafts, which they used as a surrogate for bowel handling and potential bowel injury. I think it's a nice methodology, and the authors take great strides to try and reduce bias and confounding factors, which was nice to see. They used multiple visual judgment measurements to control for learning curve effects. And in order to also minimize the learning effects as they went along, they did a crossover design. So they changed up in what order each participant would use whichever measurement method. And then all of the participants were blinded to their measurements during the study so that they couldn't learn as they went along. So I thought that was quite nice. And then they also did a bit of subgroup analysis comparing the outcomes between test subjects, which I don't really go into any further. So just summarizing their results then, for those of you who aren't familiar, this is a box and whisker plot. So it just summarizes the accuracy, measurement time, and number of bowel grafts as they went along. So just focusing on accuracy then, on the far left, you have each thick bar representing the average or median of the accuracy, with the thick bar representing the interquartile range. I've summarized the relative error as the percentage above, and then you can see the absolute measurements below, just to make it clear to everyone what the accuracy shows. So just to specify, the relative error, which is the percentage above it, is essentially a measure of accuracy, and it's comparing it's a ratio of the absolute error to the true value. And you'll see that the bowel management measurement system on the far right was by far the most accurate, with a relative error of only 2.1%, and was also the most consistent, with a standard deviation of only 2.5 centimeters between measurements. So pretty accurate. Second to that was the pre-measured tape, relative error of 4.3%. Significantly and statistically more than the bowel measurement system, but nonetheless still good, with a standard deviation of 4.2 centimeters. And then coming up the rear was the visual judgment and the instrument measurements with values as shown. By far the quickest way to measure the bowel in this study was visual judgment, which took about a minute, with very little variation in doing that. And the authors noted there was a learning curve, and that participants generally got quicker as they went along. Instrument measurement was then the next quickest, followed by the pre-measured tape and the bowel measurement system. And there was no difference between the tape and the 3D system in this study. And then number of bowel grafts, again, visual judgment was better in that sense, in that you had to handle the bowel less, followed by the tape and the bowel measurement system, which again weren't different between the two of them, but notably the instrument measurement was greater in terms of how many times they had to grasp the bowel, or the bowel phantom. I put this in just at the end of their study. They decided to ask all their users how they would rate specifically their bowel measurement system, in terms of how convenient, accurate it was, and whether they would buy it and it would benefit their patients, which I thought was quite an interesting survey to ask, considering they were asking medical students and non-medical personnel. But nonetheless, I think they wanted to boast that most people found their system convenient, accurate, and generally beneficial for the patient, but would take longer. So what the authors concluded from their study is that their bowel measurement system had improved accuracy and low variance, and it may be used as a way of standardizing how we measure bowel lengths, which is not an unreasonable conclusion to make based on their findings. Compared to instrument measurements, it has fewer bowel grasps. Unlike the pre-measured tape, you don't have to put a foreign body into the abdominal cavity, and it takes away the human error factor of having to count. But they concede that it is time consuming and it is not routinely available. And what I quite liked about the author's conclusions and discussion, it's very balanced. They do compare it to the literature, and they concede that obviously the bowel measurement system isn't available elsewhere. So they do a nice balanced discussion of all the other methods available. And so therefore they conclude that the pre-measured tape, in the absence of the bowel measurement system, is probably recommended as the most accurate method, in that it's more accurate than visual judgment, more accurate than instrument measurements, and has fewer bowel grasps, and they would recommend using that. And then finally, that instrument measurements, although probably one of the most common methods used, has the lowest accuracy, has increased measurement time, and has a significantly greater number of bowel grasps. So in the study itself, I think it was a well-constructed study. When we were discussing through it, we were quite surprised that it was presented in obesity surgery, but actually because of the good, strong methodology in terms of how they tried to reduce bias and confounding factors, I think they've put it together well. I think the authors have a very balanced discussion of the methods used to measure bowel, and I think they make appropriate conclusions, and I don't think they overreach in their conclusions from the results they obtain. Certainly to my knowledge, in my literature review, this is the first paper that I've found that compares numerous methods of bowel measurement. So I think that's interesting to see, and it's nice to see them compared in one study. And I always find it interesting to read about new technology. So although they are boasting their self-developed tool, I think it's interesting nonetheless. Another good strength, and I'll come on to the limitations, they are something that the authors recognise, and they do a good balanced discussion of their limitations and recognise that, you know, there is a need that we need to look at this in vivo. So the main limitations, the main one that comes up obviously is the fidelity of the phantom and the simulator models. And so really, if we're going to be comparing these technologies, we need to be doing them in vivo. As been discussed previously in the literature, we know that bowel tone, tissue stretch, the adhesive effect of the bowel, the effect of anesthesia on the bowel, technical aspects of whether we're using 2D or 3D cameras, using a fixed camera mount or an assistant who's zooming in and out, all of these will have an effect on how we estimate bowel length. So that needs to be taken into account when we're comparing like for like. As I mentioned earlier, the study didn't include bariatric surgeons as their test subjects. Now, this is acknowledged by the authors, and they state that they wanted a purist look at the different techniques, and they didn't want the skills of the consultants compensating for the shortcomings of some of the techniques. But undoubtedly, you know, that's something that would need to be incorporated into any future studies. I think one of the biggest biases that I did pick up was the fact that this is a self-developed tool, and although they haven't specified, my assumption is the investigators were doing the study measurements. So that's something that obviously will introduce an element of bias to their results. So I think really finally, the main point that I've taken away from this paper is, I think it's important, I think it's interesting, I think the authors raise a good point that there is a call for standardization between measurement types and studies, and they've introduced a tool to do that. But the question is it clinically relevant? Should we be incorporating it into our practice? And I just put at the bottom here, you know, the relative error between their system and pre-measured tape. In absolute terms, we're talking 1.2 centimeters over 70 centimeters. Is that clinically relevant? Probably not. Does this justify the cost of using a 3D camera, an extra screen, all the extra kit? Probably not. The authors don't talk about costs of their system, but I'm going to assume it's more than a nylon tape. So I think that's something that needs discussion. So just to end, in reading around the subject, I came across this systematic review by our colleagues in Sunderland, and they do a nice discussion of bowel length measurements as part of their limb length review. And they essentially conclude that small differences between our limb lengths is unlikely to have clinical significance. So I think that's important to note. And instead of having, you know, standardization of bowel measurements, should we just have safe ranges to compensate for errors in measurement? So I think this was just an interesting conclusion as part of their study. Thank you very much. I hope I haven't rabbited on for too long, and I welcome any questions.
Thank you, Michael. That was brilliant. That was a really comprehensive presentation, actually really interesting topic as well, especially for us in the learning phase. One of the things I think you mentioned in your limitations that was interesting, that they didn't account for kind of baseline skills. They didn't have fully trained or expert surgeons in doing this, and especially looking at the outcomes of accuracy. Was there anything that they'd accounted for in terms of learning curve of the participants? So did they randomize the order of the techniques that were used? Because it seems like the management system was always used as the final one and seems to have the good results. Yeah,
so first of all, so they didn't qualify or quantify the experience of the people that were involved. So I don't know what their baseline knowledge was. They do state that all of the participants watched an instructional video beforehand on how to do all of the techniques. So they are all grounded in that side. And then they would vary the order in which they did the measurements. So they would account for that learning curve as they went along. And that was a nice part of the study, I think, is the way they switched it up. But you're quite right that we don't know what their kind of baseline experience is and how they compare between them. As part of their subgroup analysis, they did, I didn't present it because I didn't think it was wholly relevant to the paper, but they did show that the medical students and the non-medical lay people tended to be more accurate in their measurements, but they took longer. So, which is kind of what we expect to happen. We found the residents would bash through it quicker, but they'd perhaps be a little less accurate. So it would be interesting to see what the consultants do.
No better, I bet.
What do you guys do in Portsmouth? Do you routinely use tape in all your bypasses for limb measurements?
Yeah, I'm a nylon tape adherent. What do you do, Nick?
I'm a tape man. I think my comment would be one of, God forbid, medico-legal. If you ever have to say, well, I just guessed it and visually guessed it. I appreciate the papers are out there, but at least I can definitively say that I've used a measuring device.
Yeah, and I think, once you've got used to using a nylon tape, a straightforward nylon tape is 70 centimeters long. You put a knot halfway so that you can use 70 centimeters and then a half, which would take you to quite happily a meter. And those are the two measurements for a standard bypass, whichever way around you do your limbs. And if you do two tapes, there's your one anastomosis gastric bypass limb. So it's a very simple, easy, cheap way of doing this with minimum problems of error, because using the two-handed 5 centimeter or 10 centimeter measure on your graspers, the more number of times that you actually do a grasp. So if you're measuring 1.5 meters for a one anastomosis limb, the error can be quite large. If you're not getting it exactly 10 centimeters each time, by the time you've done that, the appropriate number of times for whichever limb, the longer the limb length, the more the error, whereas a tape tends to take that away.
Yeah, agree completely.
I
Roxana?
think it reduces the amount of stretch as well, because obviously bowel is pliable and it's kind of can be stretched and the measurements aren't so standard. So using the tape in the rested state of the bowel, is that more accurate?
Yeah, well, who knows? I mean, if you're going to be pure about it, you'd ask the anaesthetist to give a bit of Buscopan so the bowel's relaxed. We just don't know. And I think until we've really wrestled with the question of should we measure the whole small bowel and then do bypasses as a proportion of the whole small bowel length, but there's a danger that by manipulating the whole small bowel you can injure it. And of the medical legal cases I come across, small bowel injury is not an insignificant proportion of that. So for the moment, I think it's a good discussion about how we should at least try and measure the bowel. And as Nick says, if you have a case where the limbs are either too short and the patient has a bad result and they decide to go at you, or it's too long because you've accidentally dropped a loop of bowel and picked up the wrong one and you've now got a much longer limb. At least if you've used a methodology that minimizes that, you have a defense. Whereas if you just said, well, I just eyeballed it, I'm not sure how well that would stand up.
Yeah, fantastic. All right. So just in the interest of time, we'll draw tonight to a close. So thank you very, very much for Portsmouth and Streamline team, Michael, George, Roxana, Shaw, and Nick. Thank you very much for joining tonight. And we'll see you all in a couple of weeks' time for Shaw's webinar on the gastric band. Good night, all.
Okay, good night.
Night.